Welcome to this video podcast for gastrointestinal endoscopy. My name is Phillip Chisholm and I'm currently a therapeutic endoscopy fellow at the Medical College of Wisconsin. On behalf of my co-authors, I will discuss the article titled Preoperative Predictors of Choledocholithiasis in Patients Presenting with Acute Calculous Cholecystitis, which was completed during my time at the University of Michigan and was recently accepted to the journal Gastrointestinal Endoscopy. The purpose of this study was to address a very common clinical scenario encountered by gastroenterologists. That is, how should we evaluate patients who present with acute calculous cholecystitis for concurrent choledocholithiasis? This becomes of particular concern when patients present with acute calculous cholecystitis and elevated serum liver transaminases and/or total bilirubin. At present, management is largely driven by the current ASGE guideline for identifying patients who are at risk for choledocholithiasis. This guideline may direct patients for preoperative MRCP, endoscopic ultrasound, or directly for ERCP on the basis of clinical, laboratory, and imaging risk factors. However, these guidelines are derived largely from studies of individuals without acute calculous cholecystitis. As a result, they may not adequately service the specific population that we know from previous studies are at higher risk of choledocholithiasis than patients having cholecystectomy for other indications. Furthermore, these guidelines have been limited by poor performance on retrospective validation studies and may lead to unnecessarily high rates of diagnostic ERCP. For these reasons, we designed this study with the purpose of defining the presenting laboratory and imaging features of patients presenting with acute calculous cholecystitis and to create a model based on universally obtained laboratory and imaging tests to appropriately direct patients to preoperative endoscopic intervention or imaging before cholecystectomy. Over a 3.5-year period, we reviewed records of patients presenting to the University of Michigan Hospital who underwent cholecystectomy during the same admission. As acute cholecystitis is a clinical diagnosis, we used the preoperative clinical impression of the surgeon performing the cholecystectomy to define our study population. We evaluated preoperative lab values, imaging studies, and endoscopy reports. From our patient population, 70% were randomly selected for univariable analysis to identify predictors for choledocholithiasis and for multivariable model development. The remaining 30% of patients were analyzed in a validation cohort to test each proposed multivariable model. 366 patients met our inclusion criteria. 65 of these patients, or 17.8%, were found to have choledocholithiasis. In our model development cohort, univariable analysis identified multiple risk factors predictive for choledocholithiasis. This included serum transaminases greater than 3 times the upper limit of normal, lipase greater than 3 times the upper limit of normal, alkaline phosphatase above normal, total bilirubin greater than 1.8, total bilirubin greater than 4, and transabdominal ultrasound common bile duct diameter greater than 6 millimeters. These results inform the development of 3 multivariable models using cumulative risk factors to predict choledocholithiasis, using the 3 derived variables felt to be most predictive. These models were then tested in our validation cohort. Each proposed model performed well with AUROC greater than 0.9. The optimal model, Model 1, utilizes only 3 variables, ALT greater than 3 times the upper limit of normal, elevated alkaline phosphatase, and common bile duct diameter greater than 6 millimeters. We found this model maximized the number of high and low risk patients, allowing for quick decision on direct referral for ERCP or surgery, respectively. From this model, we propose a management algorithm in which patients with 0 or 1 risk factor are referred directly for cholecystectomy, patients with 3 risk factors are referred for ERCP, and patients with 2 risk factors are referred for a preoperative confirmatory test, either endoscopic ultrasound or MRCP. In our validation cohort, this algorithm defined a management strategy in nearly 80% of individuals, with 70% referred directly to cholecystectomy and 9% referred directly for ERCP. The remaining patients would be referred for preoperative endoscopic ultrasound or MRCP. With this approach, only 1.4% of patients in our validation cohort would be referred for cholecystectomy who actually have choledocholithiasis. and 78% of patients referred for ERCP would be found to have choledocholithiasis. For comparison, by applying the current ASGE guidelines to this study population, we find that only 19.7% of patients would be characterized as low risk, 63.6% of patients would be characterized as intermediate risk and thus require endoscopic ultrasound or MRCP, and 59 patients, or about 16%, would be considered high risk, with only 34 of these patients having choledocholithiasis, leading to a negative ERCP rate of 42.4%. Overall, we found that choledocholithiasis is very common in patients presenting with acute calculous cholecystitis, and in our study population, the current ASGE guidelines to predict choledocholithiasis perform poorly. We hope that implementation of our new, simple, 3-variable algorithm derived from a highly performing multivariable model may better direct patient care, improving clinical efficiency and decreasing adverse events related to unnecessary ERCP. To learn more, please read the full text article available online at the GIE website. Thank you for your attention.